I'd like to acknowledge the traditional custodians of the land on which I'm recording today and pay my respects to elders past and present. I'm Kate. I'm an Australian pharmacist with more than 25 years of experience working across hospital pharmacy, community pharmacy, palliative care, aged care, and now voluntary assisted dying. Welcome to Pop Pod, the clinician edition of Prescribe or Pass. Look for me on Instagram, TikTok, Facebook, and YouTube at Prescribe or Pass. Every episode explores one medicine, one condition, or one clinical concept, explaining not just what we do, but why we do it. Whether you're a pharmacy student, pharmacist, or any clinician who works with medicines, welcome to the Pop Pod. This is episode 6 of our 8-part series on menopausal hormone therapy. So far, we have explored what happens hormonally during perimenopause and menopause, what MHT can and cannot treat, and the respective roles of estrogen, progesterone, and testosterone. In this episode, we are focusing on an area of menopause that is extremely common, frequently undertreated, and still surrounded by unnecessary embarrassment: the genitourinary syndrome of menopause, or GSM. GSM can affect the vulva, vagina, urethra, and bladder. It can cause dryness, burning, irritation, painful sex, urinary urgency, and recurrent urinary tract infections. Unlike vasomotor symptoms, which often become less troublesome over time, GSM is usually chronic and progressive. Without treatment, it commonly persists or worsens. The encouraging news is that effective treatments are available, including vulval care, non-hormonal moisturisers and lubricants, pelvic floor interventions, low-dose vaginal estrogen, and, for some postmenopausal women, intravaginal prasterone. What is GSM? The term genitourinary syndrome of menopause describes the symptoms and physical changes that can occur in the genital and lower urinary tract as estrogen and also androgen concentrations decline during and after the menopausal transition. Older terms such as vaginal atrophy, vulvovaginal atrophy, and atrophic vaginitis are incomplete. They suggest the problem is confined to the vagina, when it may also affect the vulva, vestibule, clitoris, urethra, and bladder. The word vaginitis may also imply infection or inflammation, when that is not necessarily the central problem. Estrogen receptors are present throughout the vulva, vagina, urethra, bladder trigone, and pelvic floor tissues. As estrogen concentrations decline, the vaginal epithelium becomes thinner, less elastic, and more fragile. Collagen, blood flow, and natural lubrication all decrease. The vaginal microbiome also changes. With less estrogen, epithelial cells contain less glycogen. That means there is less substrate available for Lactobacilli, which normally help maintain an acidic vaginal environment. As Lactobacilli decline, vaginal pH rises, creating an environment that may contribute to irritation, infection susceptibility, and recurrent urinary tract infections. The tissue around the urethra and bladder are also affected, which is why GSM is not simply about vaginal dryness or sexual function. What symptoms should clinicians ask about? Genital symptoms may include dryness, burning, itching, irritation, soreness, reduced lubrication, painful penetration, bleeding after sexual activity, reduced sensation, and narrowing or shortening of the vaginal canal. Urinary symptoms can include urgency, frequency, nocturia, dysuria, recurrent urinary tract infections, urge incontinence, and discomfort around the urethra or bladder. Symptoms vary considerably. One person may notice mild dryness only during sex. Another may be unable to sit comfortably, wear tight-fitted clothing, undergo cervical screening, or tolerate any form of vaginal penetration. Some women reduce or stop sexual activity because intercourse has become painful. Others continue despite pain because they are worried about disappointing a partner. Clinicians should not wait for patients to volunteer this information. Many do not know these symptoms are connected to menopause. Others assume they simply have to tolerate them. Some are repeatedly treated for thrush or urinary tract infection without the underlying GSM being recognised. A simple question about vaginal dryness, discomfort with sex or urinary changes can open a valuable conversation. GSM is not exclusively postmenopausal. Although GSM becomes increasingly common after menopause, symptoms can begin during perimenopause. They may also occur when ovarian hormone production falls suddenly, such as after bilateral oophorectomy, chemotherapy, pelvic radiotherapy, gonadotrophin-releasing hormone therapy, or endocrine treatment for hormone-sensitive breast cancer. The key point is that GSM relates to reduced hormonal stimulation of genitourinary tissues, not simply to chronological age. Do not assume every vulvovaginal symptom is GSM. GSM is common, but not every episode of genital itching, burning, or pain is caused by menopause. The differential diagnosis includes candidiasis, bacterial vaginosis, sexually transmitted infections, irritant or contact dermatitis, eczema, lichen sclerosis, lichen planus, vulvodynia, pelvic floor dysfunction, genital herpes, urinary tract infection, prolapse, trauma, and malignancy. The history should consider symptom timing, discharge, bleeding, urinary symptoms, sexual history, skin conditions, medication use and exposure to soaps, fragranced products, or other irritants. Examination is not always essential before treating uncomplicated, typical symptoms without red flags. It becomes important when symptoms are severe, unusual, persistent despite treatment, associated with visible skin changes, or when the diagnosis is uncertain. Any postmenopausal bleeding requires investigation. Bleeding after sex should not simply be attributed to fragile menopausal tissue without considering cervical, vaginal, and endometrial causes. Begin with vulval care and non-hormonal options. Treatment should be individualized according to symptoms, preferences, medical history, and treatment goals. For mild symptoms or when hormonal treatment is not wanted, vaginal moisturisers and lubricants may be sufficient. A vaginal moisturiser is used regularly, often several times a week, to improve hydration and comfort. A lubricant is used at the time of sexual activity to reduce friction. Water-based lubricants are widely available and generally compatible with condoms and sex toys, although some dry out quickly. Silicone-based lubricants last longer and may help when dryness or pain is more pronounced. Oil-based products can damage latex condoms. Patients should also avoid unnecessary irritants. The vulva does not need to be scrubbed, deodorized, or fragranced. Gentle washing with water or a bland, soap-free cleanser is sufficient. Fragranced washes, wipes, douches, bubble baths, antiseptics, and feminine hygiene products may worsen symptoms. Regular, comfortable sexual activity with a partner or through self-stimulation may support blood flow and tissue flexibility. However, patients should never be advised to push through painful penetration. Pain can create anticipatory anxiety and involuntary pelvic floor tightening, making penetration even more painful. Pelvic floor physiotherapy, vaginal dilators, and psychosexual support may help alongside treatment of the underlying GSM. When to consider vaginal estrogen. For moderate or severe GSM or symptoms that have not responded adequately to non-hormonal measures, low-dose vaginal estrogen is usually the most effective treatment. It may be supplied as a cream, vaginal tablet, pessary, or ring, depending on availability and preference. In Australia, local options include low-dose estradiol vaginal tablets and estradiol-containing vaginal products. Patients sometimes hear the word estrogen and assume vaginal estrogen carries the same risks as systemic MHT. It does not. Low-dose vaginal estrogen is administered directly to the affected tissues. Systemic absorption is generally minimal, particularly after the vaginal epithelium has been restored, although a small transient increase in circulating estrogen may occur early in treatment when the tissue is thin and more absorptive. The aim is local tissue restoration, not systemic concentrations high enough to treat hot flushes, night sweats, or osteoporosis. When vaginal estrogen binds to estrogen receptors in the vaginal epithelium, it stimulates the lining to become thicker, more elastic, and better supplied with blood. Maturing epithelial cells accumulate more glycogen. As these cells shed, glycogen becomes available within the vagina and supports the growth of Lactobacillus species. Lactobacilli produce lactic acid, lowering vaginal pH and helping restore the normally acidic vaginal environment. This makes conditions less favourable for some potentially pathogenic organisms and may contribute to reduced irritation and fewer recurrent urinary tract infections. So vaginal estrogen does not simply provide lubrication, it helps rebuild the tissue and restore the local vaginal ecosystem. Clinically, vaginal estrogen can improve dryness, irritation, urinary urgency, frequency, and discomfort. It is also recommended for postmenopausal women with recurrent urinary tract infections to reduce future episodes. How is vaginal estrogen used? Dosing depends on the preparation, so clinicians and patients should follow the product information. A common approach is an initial loading phase followed by maintenance treatment. Many products are used daily or nightly for around 2 weeks, then reduced to twice weekly or 2 to 3 times a week. Maximal benefit may take several weeks, so patients should not assume treatment has failed after only a few applications. Creams allow the dose and area of application to be adjusted and may be particularly useful for vulval symptoms because a small amount can sometimes be applied externally as directed. However, some patients find creams messy and applicators can be difficult for people with arthritis, reduced dexterity, or pain. Vaginal tablets or pessaries may feel cleaner and simpler, but do not offer the same flexibility for external application. Vaginal estrogen is usually long-term. GSM reflects ongoing hormonal change, so symptoms commonly return when treatment is stopped. There is no arbitrary age at which treatment must cease. It can continue for as long as it remains helpful and clinically appropriate with periodic review. Is progesterone required? Low-dose vaginal estrogen does not usually require additional progesterone for endometrial protection, even when the patient still has a uterus, because systemic estrogen exposure is substantially lower than with systemic MHT. However, unexpected vaginal bleeding must still be assessed rather than assumed to be caused by the treatment. Can vaginal estrogen be used with systemic MHT? Yes. Some women using systemic estrogen through a patch, gel, or tablet continue to experience GSM. Systemic MHT may help, but it does not reliably treat local symptoms in everyone. Low-dose vaginal estrogen can be added when GSM persists. This is not unnecessary duplication. The systemic estrogen treats systemic symptoms, while the vaginal product provides additional targeted treatment to the local tissues. Adverse effects and practical counselling. Vaginal estrogen is generally well tolerated. Some patients notice temporary irritation, discharge, or local discomfort when treatment begins. A pessary or tablet may leave residue, so using it at night and wearing a panty liner may help. Some cream bases may weaken latex condoms, so patients should check the product information. Adherence is often more difficult than clinicians realise. A patient may complete the loading phase, feel better, forget maintenance doses, and then find symptoms returning. Linking twice-weekly doses with regular days, such as Mondays and Thursdays, can help. If symptoms have not improved after an adequate trial, consider adherence, whether the diagnosis is correct, whether external vulval symptoms need targeted treatment, and whether pelvic floor dysfunction or another condition is contributing. What about breast cancer? This requires careful, individualised discussion. For women without a history of hormone-sensitive cancer, low-dose vaginal estrogen has a reassuringly safety profile and is not equivalent to systemic MHT. For breast cancer survivors, non-hormonal treatments are usually tried first. If they are insufficient, low-dose vaginal estrogen may be considered after discussing symptom severity, recurrence risk, current treatment, and uncertainty in the evidence. The decision may be more straightforward for someone who has completed treatment or is taking tamoxifen, but greater caution and oncology involvement may be appropriate for someone taking an aromatase inhibitor because these medicines aim to suppress circulating estrogen to extremely low concentrations. So the important message is that a history of breast cancer should not result in GSM being ignored. Symptoms can be severe, and avoiding discussion of effective treatment can also cause harm. Where does Prasterone fit in? Prasterone is another local treatment option. It is known as dihydroepiandrosterone, or DHEA, and is a naturally occurring steroid precursor. In Australia, intravaginal prasterone is available as Intra Rosa, a 6.5 milligram vaginal pessary for postmenopausal women with moderate to severe symptoms of vulval and vaginal atrophy. Unlike vaginal estrogen, which supplies active estrogen directly, Prasterone is converted within vaginal cells into small amounts of estrogens and androgens. This is called an intracrine effect. An endocrine hormone is produced in one organ, travels through the bloodstream and acts elsewhere. An intracrine treatment is converted into active hormones within the cells where it is needed. Prasterone enters the vaginal cells as DHEA and is converted by enzymes inside those cells into estrogens and androgens. These locally produced hormones bind to estrogen and androgen receptors, changing gene expression and promoting epithelial maturation, collagen formation, blood flow, lubrication, and tissue integrity. The active hormones are then largely metabolized within the same cells before inactive metabolites leave the tissue, helping to limit systemic exposure. This local conversion can improve vaginal structure and function, increase superficial cells, and reduce vaginal pH and improve dryness. The usual dose is one 6.5 milligram pessary inserted vaginally once daily at bedtime. This differs from many vaginal estrogen regimens, which move to twice-weekly maintenance after an initial loading phase. Daily administration may suit some patients but may feel burdensome or become more expensive for others. Vaginal discharge is the most common reported adverse effect and may result from the melting of the pessary vehicle rather than infection. Prasterone may be considered for a postmenopausal patient with moderate to severe symptoms, particularly painful sex, someone who prefers it, cannot tolerate vaginal estrogen, or has not achieved adequate relief from other measures. It should not automatically be presented as more effective or safer than vaginal estrogen. It is a different option with its own evidence base, dosing requirements, cost considerations, and contraindications. It should also not be described as completely non-hormonal. Although predominantly local, it produces estrogenic and androgenic metabolites within vaginal tissues. Evidence in women with a history of breast cancer remains limited, so Prasterone should not be assumed to be a simple workaround when estrogen exposure is a concern. What about vaginal laser treatment? Patients may ask about vaginal laser or other energy-based procedures because they are marketed as hormone-free and restorative. Current evidence does not support routinely recommending them for GSM. They can be expensive, long-term efficacy and safety remain uncertain, and adverse effects including pain, burns, and scarring have been reported. A lack of hormones does not automatically make a treatment safer. The pharmacist's role. Pharmacists can make GSM treatment accessible and manageable. We can explain the difference between systemic MHT and low-dose local treatment, check whether the patient understands loading and maintenance schedules, normalize long-term use, and explain that symptom recurrence after stopping does not mean the medicine has caused dependence. It means the underlying hypoestrogenic state remains. We can troubleshoot applicators, administration timing, residue, discharge, and missed doses. We can also ask whether repeated prescriptions for antifungals or antibiotics may be masking an untreated underlying problem. And we can identify red flags: new postmenopausal bleeding, bleeding after sex, persistent discharge, vulval skin changes, a lesion, severe pelvic pain, hematuria, or symptoms that do not improve with appropriate treatment should prompt medical review. We should also use inclusive and anatomically accurate language. Not every patient with GSM identifies as a woman, and not every patient is sexually active with a male partner. Asking what symptoms are affecting the individual and what improvements matter to them is more useful than making assumptions. The key clinical message: GSM is common, chronic, and treatable. It is not simply a dry vagina, and it is not an inevitable inconvenience that patients should be expected to tolerate. It can affect urinary health, sexual function, sleep, mobility, relationships, and quality of life. Non-hormonal moisturisers and lubricants can help mild symptoms and remain useful alongside other treatments. Low-dose vaginal estrogen is highly effective for many patients, has minimal systemic absorption, generally does not require additional progesterone, and can be used alongside systemic MHT. It also has an important role in reducing recurrent urinary tract infections in postmenopausal women. Prasterone is another local hormonal option for postmenopausal women with moderate to severe symptoms. It is converted within vaginal cells into estrogenic and androgenic metabolites, but it requires daily administration and should not be presented as entirely non-hormonal or automatically safer than vaginal estrogen. When we ask sensitively and matter-of-factly, we give patients permission to discuss symptoms they may have endured silently for years. Some reflective questions. Do I routinely ask patients in perimenopause and after menopause about vaginal, vulval, and urinary symptoms rather than waiting for them to raise the subject? Can I clearly explain the difference between systemic MHT and low-dose vaginal estrogen, including why additional prasterone is not usually required? When a patient reports recurrent urinary tract infections, urinary urgency or dysuria, do I consider GSM as a possible contributing factor? Can I explain how intravaginal prasterone works and how it differs from vaginal estrogen and why it should not be described as completely non-hormonal? Do I recognise the red flags, including postmenopausal bleeding, vulval lesions, and persistent symptoms that require further investigation rather than empirical treatment? In the next episode, we will turn to MHT risks, contraindications, and complex clinical situations. We will look at who may need additional caution, when specialists' input is appropriate, and how to approach treatment when the clinical picture is not straightforward. We will also revisit the Women's Health Initiative, the WHI, because understanding what that study did, what it found, and how its results were interpreted is essential to understanding many of the fears and misconceptions that still surround MHT today. Until then, keep asking the questions patients may be too embarrassed to ask themselves.